Good morning, good afternoon, or good night, depending on the region and the time that you're viewing this presentation. My name is Jordan Robinson, and I'm a general surgery clinical research resident at Atrium Health Carolinas Medical Center. And I'll be discussing an investigation titled, "Is there an additive effect of outcomes for robotic surgery and ERAS?" conducted by the Division of HPB Surgery. We'll begin with a brief overview of what this presentation contains. First, we'll start with some background regarding minimally invasive and robotic surgery, as well as some background of the benefits of ERAS pathways. We'll continue to discuss the investigation that is proposed, concluding with our results and a synthesis of our findings. And to begin, we'll take a look at some milestones for minimally invasive approaches to hepatic resection, including important milestones that have impacted the field's current paradigms, including the Louisville Statement, the Moriaka Consensus Conference, and the Southampton Consensus Guidelines and their release in 2018. These milestones, in concert with improvements in technology, have led to an increased interest in minimally invasive approaches to hepatic surgery. And this is reflected in the publications that we see per year in the literature. In line with public literature and other surgical disciplines, benefits such as decreased requirement of oral analgesics, decreased rates of complications, and reduced hospital lengths of stay have been associated with minimally invasive approaches. This benefit has also been displayed in robotic surgery, which stands to reason as robotic surgery is a form of minimally invasive surgery, although the literature is not quite as robust as for laparoscopic surgery. And so the question is, with similar statements being true of ERAS, how do we combine these two schools of thought? I think the first question is to address and make sure we understand what exactly ERAS is. So what is it? So ERAS is essentially the standardization of postoperative pathways through evidence-based strategies and the tracking of postoperative outcomes. This ERAS review published in JAMA Surgery highlights the protocol's recommendations and the associated strength of each recommendation. The strongest to-dos and to-avoids of the recommendations are summarized here. But most importantly, ERAS works, and the outcomes, which are a part of the same publication, essentially reveal that ERAS simultaneously improves outcomes postoperatively and decrease costs for patients and for hospital systems. And so our question is, with potentially overlapping benefits, does the use of minimally invasive surgery or minimally invasive approaches, does that obviate the need for ERAS? Do the benefits overlap, or are their effects additive? And our hypothesis is no, that these effects are in fact additive. And therefore, to further investigate, we constructed a study to delve into the details. Speaking of details, here are a few details regarding our institution and our division to give some context for the study, as well as dates for universal ERAS pathway adoption across procedures, with the two procedures of interest in this study highlighted in yellow. Essentially, we looked at all robotic cases, as well as open cases over the same period, starting back in 2008, going all the way to 2019. And we took the time period where universal ERAS implementation was applied to those procedures at our institution, and we looked at the outcomes before and after to see what the exact effect of ERAS was on outcomes, with a particular interest in robotic surgery. And so we began by creating propensity matched cohorts with the outcomes of propensity matching displayed here for laparoscopic and open cases. 0 is the before ERAS period, and then 1 is the after ERAS period. And as you can see, patients were matched based on age, sex, race, BMI, presence of diabetes, smoking, and history of prior surgery. And there are very little differences here, suggesting that the match was quite good. This slide depicts the effects of robotic surgery on hepatectomy outcomes. This is before ERAS, and here you can see the differences in length of stay based on the type of procedure that a patient underwent. Notably, robotic surgery did a little bit better than even laparoscopic surgery on hepatectomies, keeping in mind that this is a combination of major and minor hepatectomy. Unsurprisingly, complication rates for open surgery were significantly higher than both robotic and laparoscopic surgery. And one thing to note, in our cohort, there were no conversions in the robotic group, but there were a small amount, 5%, conversion to open rate in the laparoscopic group, which is something we'll come back to later in the presentation. This next slide takes a look at minor hepatectomies only before and after the implementation of ERAS. And so on the left, we have essentially the same similar numbers to the previous slide, but on the right, we have the addition of the ERAS implementation. And highlighted, again, are the effects, in particular, the effects on open surgery, which we found to have the most profound difference between the pre and post ERAS periods. But in particular, decreased complication rates, decreased length of stay, decreased 30-day admission for open surgery in particular. Looking at major hepatectomies, we see an even greater difference in the pre and the post periods for ERAS, especially for open surgery. Interestingly, there's an increase in the length of stay for major hepatectomy, which could be the result of the difficulty in the learning curve of completing those procedures laparoscopically. You see a smaller increase for major hepatectomies with regards to length of stay in the robotic group. And again, looking at 30-day readmission, we see the greatest effect for the open group, and no conversions for the robotic group once again. Taking a look at the overall effect of ERAS on robotic surgery, again, the left is before and the right is after the implementation of ERAS. We do see essentially no difference for mortality, 30-day readmission or length of stay, but a decrease or a trend potentially towards a decrease in the rates of complication, although it does not reach statistical significance here. The last bit that I would like to review is the effect that ERAS has on cases that require conversion. And so the far left columns in each triad, which are highlighted or circled, have a portion circled in red, are laparoscopic conversions. So all those are converted cases. And as you can see, patients that required a conversion to open had significantly worse outcomes even than open surgery itself, with an extended length of stay, both pre and post, high rates of complication and mortality, although 30-day readmission was not severely affected by these conversions. The other thing to note here is that the before and after for ERAS, and so when patients did require a conversion to open, they did significantly better after the implementation of ERAS, which is again consistent with the effects that we saw of open surgery pre and post ERAS. And so overall, robotic surgery was associated with a similar length of stay and complication, and actually decreased complication rate compared to laparoscopic surgery overall. However, it did display a decreased conversion open rate. ERAS itself, across open and laparoscopic and robotic procedures, was associated with a decreased length of stay, decreased complication rates, and decreased 30-day readmission rates. The greatest effect of ERAS was seen on patients that underwent open surgery, followed by laparoscopic surgery. And robotic surgery actually did have the least effect, although we did see a benefit, particularly in rates of complication for that group. Unsurprisingly, the effects of ERAS were seen more readily for all patients undergoing major hepatectomy. And we also noted overall decreased complication rates for patients undergoing robotic surgery, as displayed in the slide, focusing on just robotic surgery before and after. And so the bottom line, I think, for this investigation is that ERAS is still something that can benefit all patients, with the greatest benefit being seen for open surgery. When comparing robotic and laparoscopic approaches, if a patient requires conversion to open, that's when the ERAS protocol is of greatest benefit. And so I'd like to take this time to thank the entire HPB team, thank ILLS for this opportunity to present our study, and happy summer from Charlotte.